Good afternoon. I'm sorry for the delay. We rushed over from one building to this building and had to go from one type of laptop to another, so I apologize. We got through the technical difficulties, which actually, as a colorectal surgeon, I call for help all the time for this, because I don't know what we're doing with technology. I'm Mark Welton. I am the Chief of Staff at Stanford Hospital. I'm also the Chief of Colorectal Surgery. I'm a full professor of surgery at Stanford and have a full academic practice. Which actually, what that means is that I take care of patients, and we have a research group, and as Chief of Staff, I'm also involved with dealing with the behavior around 2,000 physicians, which is about like dealing with the behavior around 2,000 15-year-olds most of the time. So as a disclosure, I am the Chief of the Scientific Advisory Board for a company called Prescient Surgical that was developed around a product that I developed a couple of years ago with a couple of young guys who are a lot smarter than I am, who took an idea that I had and hopefully will bring it to market someday. Right now it makes no money, so there's nothing to disclose really, but I do have to disclose that. So briefly for our talk this afternoon, I'm going to go over an initial disclaimer, then talk about my background a little bit, which I was doing anyway, but then I read the more fully expanded description of what I was supposed to do today. It actually said I should go into my background and how I got where I am. Then we're going to talk a little bit about healthcare, whether or not it's a right or a privilege. Education, whether or not that's a right or a privilege. Insurance, whether that should be mandated or only if it's affordable. And then really get into one of the major drivers for healthcare costs, that is end-of-life issues. And finally ask, who should make money on healthcare? So my disclaimer is I am anything but an expert. I am a colorectal surgeon by training. I went back to Harvard in 2007. I got a master's in healthcare management. I was flying back and forth across the country for 2 years. So I was fairly involved. I learned a fair bit then, but I'm not an expert at all in healthcare costs and how to control healthcare costs. These are very controversial topics, which means there's a lot of religion and very little fact. These are just my personal musings. Actually, I put the talk together mainly on a flight back from Chicago on Wednesday from doing oral exams for the American Board of Surgery. And I was just thinking about this on the way back, and then talked about it yesterday with my daughter, who's just graduated from Cal and is applying to medical school, and said, would anybody even care about this? She goes, no, I think this is good, so that was better. And then I changed it a little bit this morning at 5 a.m. So I'd encourage this to be an active conversation. Raise your hands, challenge me, tell me that you think I'm an idiot. That's great. You'll join a long list of people. There really are no truths in this topic, right? There's no truths. There's a lot of belief, but the truths are really informed by our beliefs. But hopefully there's no truthiness either, a la Steve Colbert. First of all, not so much this audience this afternoon, because there's not as many students as the first two that I did at 2 and 3, but I want to emphasize I really am like the people who are in these classes. I was a Davis undergraduate. I graduated from 1978. Where I was giving my talks for the first 2 hours, Wellman, I walked in there and I had a little PTSD because the freshman fall quarter, I was on the water polo team and trying to flunk out of college. So that was where I took Calculus 1A. I did very poorly. My first ever F in my life was in that building. I staggered home, thought I will never go to medical school. What am I doing here? I can't even get through college. But I survived, and actually took statistics in that class, in that building as well, which also was that was worse than calculus for me. But I had Calculus 1A, 1B, and 1C. I never learned statistics, so I went to Harvard in 2007 and took it as a 50-year-old man who finally understood some of the principles. But I was also one of the people in medical school. Let's see, where are we now? So across the quad, which was across from where I was at Wellman and the quad, and then there were these old buildings where we had the pre-health sciences advisor. This woman sat down with me when I was a junior here, and she said, you'll never get into medical school. There's nothing remarkable about you. You're a tall male whose father was a physician, even though my parents were divorced, who has, got average test scores, average GPA. There's nothing outstanding about you. You'll never get in. I said, thank you very much. So I left very encouraged by that. And that's not changed. Those people are still out there telling you you'll never get in. So I tell you, ignore them. They don't know what they're talking about. I was rejected my first year. I applied. I got one interview my first year I applied. I got interviewed at Stanford. I did okay with the student interview. I walked into the faculty interview, and it was like, uh-oh, this is not going to go well. I opened the door, and you know when you see somebody and you know they hate you on site? This person hated me on site. I had sort of long blonde hair. I was tan. I used to be in the water a lot. He was not tan and blonde. And so, and sure enough, when the first thing he said to me was, I don't even know why we gave you an interview. I laughed. I said, neither do I. Because if you could explain the admissions process to healthcare, I mean, to medical school, you know, you would get a Nobel Prize. And so the next year I applied, I got many more interviews. I didn't get interviewed at Stanford, though. They didn't want me back. I got a lot more interviews, and I got in actually to Davis and UCLA and a few other places. And I was born and raised in Northern California, and as a true Northern Californian, you stand up and you say the Pledge of Allegiance, the flag, and you'd say, and I hate Southern California before you sit down. And because they take all of our water. And so and they hose down their driveways, and our fish are dying, and their driveways are clean. And but I swallowed my pride, my years of prejudice, and moved down there, and I spent 12 years in Los Angeles at UCLA Medical School, UCLA residency, and actually stayed on the faculty there for a year before going out to do a fellowship in colorectal surgery at WashU, my big excursion out of California, really risky. Spent a year in WashU and then came back to San Francisco. I was at UCSF for 8 years, and then went to the dark side, went down to Stanford. After the divorce of UCSF and Stanford, I was very unpopular when I did that, but it was the right decision for me and my family. And I've been at Stanford since 2001. As the chief of colorectal surgery, building a program there out of nobody. Now we have 5 colorectal surgeons. And been the medical director of the cancer center there for a couple of years, and now I'm the chief of staff for 2 years, which is an elected position. Actually, I was asked to run for the job when I was in a hospital bed at Stanford in the ICU. It was a moment of insanity. As a patient, I said, sure, why not? But I took it on, and I'm learning a lot. So it's a good job. You get to have a lot of conversations about, again, physician behavior and nursing behavior. Medicine is an incredibly rewarding career. I'd encourage you to go into it. I love what I do 97% of the time. I hate what I do 3% of the time. You know, when somebody dies that you know, you worked hard to keep alive, that's not a good feeling. When you do something that hurts somebody, that's not a good feeling. And if you're going to go into healthcare, you're going to do something that's going to hurt somebody. And if you can't accept that, or then you shouldn't go into healthcare. Because your job, if you're in healthcare, is to do the best you can taking care of somebody, make the best decision you can make at the time. And then when you make a poor decision, admit that you made a poor decision to yourself, forgive yourself, and learn from that poor decision so that you don't make the same poor decision again. Unfortunately, we're human beings, and one of the best surgeons I ever met, ever worked with, one day he called me to his office, and he was walking around his desk just like this. He's like, how many times am I going to make the same damn mistake? I can't believe I made the same mistake again. And he's the best surgeon I ever met. And we will make the same mistakes. And you then still have to forgive yourself and move on and continue to try to take great care of patients. But admit it, because that's the only way you can learn. If you deny it, you'll never learn, and that's the worst thing. I really worry about that when I see that in residents and medical students. And academic medicine, I love what I do. It's a challenging career. It's exciting. It's ever-changing. And it's incredibly rewarding because you get to work with medical students and residents who are a hell of a lot brighter than I ever was. Like, I was flunking out of that calculus class over there, playing water polo and surfing, and you know, I'm not nearly as smart as a lot of these kids who are coming through these days. If you go into medicine, recognize that it's a service industry. A service industry. Patient care means you're taking care of people, providing a service. If you don't like that, don't go into medicine. because people are wanting you to be more and more engaged with them all the time. And you will be a peace worker. So if you go into law and become a partner in a firm of 100 people, you can be in the Bahamas or Tahiti or Hawaii having a great time, and your firm is working for you and you're making money. It's not true in healthcare. Every patient you take care of, you'll get paid for taking care of that patient, but if you're not taking care of patients, you're skiing at Tahoe with your kids, you're not making money. That's great, though, because you don't go into medicine to make money. You should be clear on that. You'll make a decent living, but it's not like you're going to go get rich. And there are increasing expectations of healthcare providers. You need to be available 24/7, right? My cell phone is, my wife hates my cell phone. It's always with me because my patients want to find me. Now, you don't always, it is a decision that you can make to not always be available. You join a group practice, you have people covering for you, and that's fine. But my patients can find me. I landed in New Delhi at 2:30 in the morning in March, and my patient in San Francisco, it was noon in San Francisco, and his mom was calling me to tell me that he is having a problem. So patients want to be able to access you. They want to be able to email you. They want you to respond. They want you to respond in a courteous fashion and promptly. And this is not going to get, this demand is not going to get less. They also want you to be, to have increased humanism. They want you to be able to connect with people. This is an interesting thing for me. People applying to medical school, you take physics, biochemistry, organic chemistry, inorganic chemistry, zoology, genetics, and where in there are they teaching humanism? Where in there are they teaching you how to connect with people? It's an interesting process because we select these people who, when I was a student, we used to call it going and getting buried in the stacks, right? You'd go and study where just there are books all around you, and you study to 4 o'clock in the morning. We don't have, or I don't think people go study in the stacks anymore, but we would study in the stacks. And I don't know that that leads to somebody who knows how to connect with people. What you've selected for is somebody who can excel in high school physics and excel in college physics, and then go into medical school and excel in the sciences of medical school, and then go through their residency, and suddenly you want them to be able to connect and understand how you feel and can be compassionate and empathetic. We're not selecting for that. So it's a bit of a conundrum, I think, that we need to fix. And for the public, performance is expected. It's not, that's a given. You're gonna perform, and you're gonna perform at the top. And our focus really then becomes, what about your service? What about your safety and quality? Performance is really understood. Everybody thinks that the performance is all gonna be the same. And so this is a huge focus now within healthcare. If you look at it, if you go to the University of Utah webpage, you can look at the star ratings on their doctors. Cleveland Clinic, you can look at the star ratings on their doctors. Stanford's going to put it on the web. You can look up how good a doctor I am. They filter it for obscenities, and they filter it for clearly crazy people, they say, although I'm not sure they will. But otherwise, everything else is out there. Well, that's an interesting idea. So people are very focused then on, we expect the physicians to be pleasant, welcoming, compassionate, empathetic, caring, available, responsive, provide continuity of care, and be familiar with us. At Stanford, we say, know me, show me, care for me. That's the expectation. And that's great. I mean, that's really what we should be expecting. But we also should be understanding what quality is. Is quality a nice doctor? Is quality a nice receptionist? Is quality ease of making the appointment? The doctor or staff calling you back? Is quality short waiting time in the waiting room? Or is quality avoiding avoidable complications? Yeah?
My mother's elderly and difficult, and those 4 things on the top do make her
Yes.
feel a lot better, and she gets much better service when she's not angry.
Yeah, no, so I would actually say that all of us think that these are things that we want. And and I completely agree with that. You need to be able to provide good service. And in fact, Starbucks, right? They understand service. So if you're at Starbucks and you walk in, you're the third person in line, that barista looks to the third person in line, makes eye contact. As soon as they've made eye contact, you're now engaged. You're now not going to walk out. You're no longer in a line. You're now in a personal relationship with that barista who's made eye contact with you. Starbucks knows that, right? So there's queuing theory and there's service around that. And in fact, Whole Foods, they don't do that. Safeway doesn't do that. They have lines because of space constraints and also other things about the shopping market experience. But so service is an important thing, and service is something that has been neglected in healthcare, and in particular neglected in academic medical centers. Because we've always said, if you want to come to Stanford, you can get the best care in the world, but we're really not worried about service. You know, because as a physician, actually, I can't impact service. If I'm in a private office and my front staff is belligerent, I can fire them. At Stanford, if my front staff is belligerent and I say something, I'm now in trouble for complaining. And that person's got a job, right? So it's an interesting problem, and I'll touch on it a little bit more. But so we really, I think as physicians and healthcare providers, we need to be involved in the quality definition, because quality really, for the public, is an expectation in my mind. You expect quality. You think the doctor's got to be knowledgeable, skilled, and up to date. But in fact, not all are. It's hard to do. A lot of people aren't providing the leading cutting-edge care. We see that all the time at tertiary quaternary care medical centers. Again, patients will come in with very challenging complications that were completely avoidable, that were created by poor decision-making, but they love their doctors. And so it's an interesting, they think they got great quality care, and we think they got horrible care, but their doctor's a nice person, so they love their doctor. So, you know, I think you have to be a nice person and deliver the best possible care is my only argument. So as we look at quality, then where are ways to deliver quality? Well, if you look at the auto industry with Toyota Lean, which was Deming, who was here in the United States, but nobody in the United States would listen to him. Toyota listened to him, and they built these teams that would build cars. And they discovered ways to decrease variability with standard work and standardized approaches. Well, we can do that in healthcare. Well, people in healthcare say, oh, these aren't widgets we're making, these are people. Well, in fact, you know, a lot of, you know, laparoscopic cholecystectomy, taking somebody's gallbladder out, it's pretty much the same thing every time, except for the 15% of the time it's not, right? And then we say, oh, but we're at academic medical centers. I'm a famous surgeon. I only take care of the colorectal surgeon's colorectal patients, because that colorectal surgeon in the community goes, this is too complicated for me. I'm going to send it to Stanford, or when I was at UCSF for Mark Welton to take care of it. And Mark Welton feels great about how great he is, and oh, everybody's different, and I can only do these cases, and these are these big, complicated cases. But in fact, my big, complicated cases pretty much turn out to be the same sort of big, complicated cases. Recurrent rectal cancer, I do it the same way every time. Inflammatory bowel disease in kids, okay, I do it the same way every time. So you can get to standard work even though you've got exceptionally complicated patients if you compare it to the general population. So decreasing variability allows you to focus on the outliers. It facilitates learning for the physician and the institution, and it facilitates improvement. You can say, okay, the next time I see a patient with this set of complications, I will then learn to approach it a different way. This is this whole idea behind big data that was in the New York Times magazine on Sunday, and the woman was interviewed last week on NPR, is trying to learn from our experiences in our institutions and improve sort of active improvement on a day-to-day basis. So when you create standard work, though, you want to be careful to engage the caregivers in that area. I'm being filmed, I don't know if I should say this, but in the mid-2000s, there's this huge push to implement tight blood glucose control for everybody. They had learned that in cardiac patients in the ICU, after open heart surgery, that if they controlled the blood sugars very tightly, that they had better outcomes, fewer wound infections. And sternal wound infections are horrible wound infections. So they said, well, we should do tight blood sugar control on everybody. Well, I got yelled at for not being, you know, not being a team player, because I said, wait a minute. how do we know that it's not good to have a high blood sugar if you're a 43-year-old healthy person who's having an inguinal hernia repair? Whereas the data say that that's not good. It's like, oh, Mark, come on, stop being such a jerk about this. Do what we say you should do. Well, unfortunately, they started to do that nationwide, and patients died. Because actually, stress response is to have high blood sugar for a little while. So if you're a normal, healthy person, it's good to have high blood sugar, as it turns out. And so all of a sudden, we're back to the same blood sugar control guidelines that we had 10 years ago, because we tried different guidelines and patients did worse, and now we're back to where we were. So you need to engage the caregivers in the area that you're going to be developing standard work around, so they can be involved in making that standard work, because they really are, as they call them, the content experts. So you can't have a pediatric infectious disease expert who does immunology of whatever talking about colorectal surgery, because they don't know about it. And I can't talk about that because I don't even know what it is. So, and then you let the content experts define quality, and then make sure your observations, and again, go back to the statistics classroom, which I didn't get when I was here, but if you do a sample population, we have to say that this classroom is representative of this whole university. And if it's not, you can't take what was done in this classroom to the whole university. Doesn't work. It was 2008 before I ever learned that. It's like, oh, okay, now I get it. And by doing that, then you decrease the well-intended but unintended consequences. Your well-intended efforts lead to unintended consequences that can be really quite challenging. Take the Libby case out of New York, where that young girl in New York had the ear infection, and they said that the tired resident was responsible for the patient's death, and all she had was a bad ear infection. That's sort of a very truncated version of it, and I don't know that I really agree with that version, but that's what they put out in the public. So they said, okay, so we're going to decrease resident work hours to get people to not work so hard so they won't be so tired, so they won't make these sorts of mistakes. So by doing that now, we've mandated resident work hours. You can't work more than 80 hours a week if you're a resident. And everybody says, wow, that's 2 jobs. How's that cutting back? Well, when I was a resident, we worked 110 to 130 hours a week, depending on the week that you're on. And so that is a cutback. But what has come out of that is more handoffs. Well, we don't know how to hand off. I don't know. We're not trained in handoffs. So now you have the errors in communication. And so suddenly the patient who's being in the hospital being cared for by somebody who's never met the patient. And there hasn't been effective communication, and so there are increased errors associated with that. So fewer resident work hours, so the residents are in theory getting more sleep, but residents are young adults. They're all out getting drunk anyway, right? That's what they do. So that's okay. But they're not getting more sleep, but they're also just not working. And now we have more errors and handoffs. So it's never really those unintended consequences. So let's switch gears now. Healthcare, a right versus a privilege. Now we're getting into some murky waters here. So if it's a right, who pays for that right? All right? If it's a right, who provides it? Because how are you going to pay the people to provide it? How are you going to compensate them? And now, who pays for those who can't pay right now? Right? Who pays for the underinsured and uninsured patients? If it's a privilege, are you really going to walk by the people who can't afford to pay? Is that really right? In the United States right now, we are 29th in the world in healthcare. We're equal to Portugal. So Germany, Britain, Canada, Sweden, they're all better than us. Yet we're told on a daily basis that we have the best healthcare in the world. We have the best healthcare in the world if you're in the government, because you have access to the best healthcare in the world. We have the best healthcare in the world if you have unlimited resources. But fewer and fewer of us have unlimited resources. So those people, we don't have the best healthcare in the world. We have 22,000 people die a year because they can't get access to healthcare. As the richest country in the world, I struggle with that. But more than I struggle. I think that's wrong. So what happened with this paying for healthcare? How did we get this dissociation between money and utilization? So in the American healthcare system, you can walk into the doctor's office and demand a CT scan for something that you don't need a CT scan for. I want to have you scan my big toe because I stubbed it. It's like, well, wait a minute. Can't we just buddy tape it together for 2 weeks and come back and see me and let me know how you're doing? No, I want a CT scan. Maybe I've got cancer of my big toe. And or the latest fear, I've got Ebola. I've been exposed to Ebola. No, you've been in a nursing home for 2 weeks. You could not have been exposed to Ebola. But anyway, so you can demand health care, and you don't assume any of that cost, right? Because your insurance company has paid for that. And that came because employers provided the benefits. How did that start? In the 1940s, in discussions between companies and unions. Unions wanted a raise. The companies couldn't give the raises. So they said, well, we can't give you a raise, but we'll pay for your health care. That's a lot of money. So now all of a sudden, as a consumer, you can ask for anything you want, and you don't have to pay for it. You got kids in a candy store. Mom, I want 3 candy bars. I don't have to pay for it. Well, fine. There's a complete dissociation between the cost of what you want and the various tests and whether or not you need them, because somebody else is paying for it. Now we're moving away from that, and we're moving away from that historical model of the employer providing the insurance, and more you are being forced into the situation of choosing high deductibles, and your co-pays are going up. And then people's decision-making process about whether or not they want that test is a little different. Additionally, the interesting thing here is, as a provider, it is easier to order an unnecessary test than it is to explain to the patient why they don't need it. Because they'll come in and they'll say, I got this off the internet. It says I should have this. And it's like, well, that's not you. It's got nothing to do with you. I'm your doctor. I know all about you. That is for patient over here. No, I need this. And so doctors, in particular in primary care, they got 10 minutes to spend with each continuing care patient. And it can take 40 minutes to explain to the patient that they don't need the test. And then, like you said, for your mom, that patient can leave dissatisfied that he or she didn't get what they wanted when they came to the doctor's office. And now they'll go to Yelp and say, this doctor wasn't very nice. It's like, no, the doctor was appropriate. You didn't need that test. So this is one of the things that drives healthcare costs up. So when you talk about the undercovered, the uninsured, the underinsured, where's that care provided? It's not provided at Kaiser, right? That's a not-for-profit, but they won't let you in there. So it's provided at county hospitals, teaching hospitals, and so you and your parents pay for it. That's because it's all paid for in taxes. That's what keeps those things open. So that's not free health care. That you end up paying for that. So are there societal benefits to free health care, which is the health care that you pay for? Should we give free health care? Is it good to immunize people who can't afford immunizations? Sure. Herd effect, right? Plus, so now your kids can safely go to class and not have somebody who's not immunized to whooping cough next to them and spreading that throughout the classroom, right? So there's benefit there. Well, baby checks certainly have benefit. Hypertension clinics, you control the blood pressure of a patient. They don't have the side effects from their hypertension. They don't get strokes. They don't have kidney disease. Diabetes, same thing. You don't lose your legs because of your poorly controlled diabetes. So if you provide free care and control patients' diabetes, then the cost to society is less because you don't deal with the amputations, the renal failure, the dialysis, the kidney transplant patients. They're all avoidable. That if you gave the patient better diabetic health care, you wouldn't have those downstream complications. A great example in India. They were looking at these villages in India, and they were finding these men that were really not contributing to their families. They weren't cooking, they weren't cleaning, they weren't taking care of their grandchildren, and they were really a tremendous burden on their villages. And why? They had cataracts, they couldn't see. So they went through this whole social network where they reached out to these tiny villages and developed trust with those elders, I'll use the word, I don't know that that's what they're actually called, but the people within the villages, and then got them to trust them enough to bring in those people with cataracts on buses into major cities, have cataract surgery and be given glasses and sent back to the villages. then they were cooking and cleaning and taking care of their grandchildren. They're no longer a burden on the society, and the parents could go back to work because they didn't have to stay home to watch the children, and it was all through free health care, right? But it's a tremendous, it's not free. I mean, the society actually benefited tremendously from it. So now we'll get into behavioral costs. So I'm on a college campus, right? Drinking, right? We should be able to drink all we want, smoke, eat too much. Look at the morbid obesity in this country. It's just, I didn't overeat. I was overserved. I mean, there's no responsibility. They served me too much. And then lack of exercise. One really interesting thing, this is published, I think, in the late 90s. I don't actually remember exactly when. But if you compare Canada to the United States, and you look at healthcare costs, we're North Americans, right? I mean, Canada is really no different than the United States in obesity, alcohol abuse, I mean, drug abuse. Look at the mayor of Toronto, right? I mean, so it's the same. He may be a little crazier. But if you look at the cost associated with taking care of people who've been shot in the United States, taking care of people who've been shot, you could provide free health care to everyone in the United States if you just took away guns. To me, that's amazing. They don't have guns in Canada. They don't have the health care costs that we have. It's as simple as that. Then on the college campus, my favorite topic, it's against the law to ride a motorcycle without a helmet. But if you're over 18, you can ride around this campus, as I see everybody doing, without their helmets. So February 5th, 2011, I was out doing what my cardiologist told me to do, make sure I was getting my age worth of aerobic workout a day. And I think it was 50, I don't know, what am I? I was probably 54 at the time. Yeah, it was 54. And I was riding my bike down a little bit of a hill. I was doing about 28 miles an hour probably at the time. I was just getting started on my ride. And a 19-year-old boy made a poor decision, made a left-hand turn coming uphill in front of me. I broadsided him at 18.4 miles an hour according to my Garmin. So the speed I was traveling at the point of impact, I hit his car at the A post, which is the strongest part of the car. The sheriff at the scene said he'd never seen a body make such a dent in the A post of a car in his entire career. I hit the car with my right side. I flipped up on the roof of the car, smashed my head onto the roof of the car, bounced back off the car, apparently was in a T-stand and fell over. I broke my right clavicle. I crushed my sternum. I broke both my first ribs, both my second ribs, shattered my left shoulder, crushed my pelvis, and broke my pelvis in 5 places. I bled down from a crit of 50 to a crit of 20. 3 days in the ICU, 3 weeks in the hospital, 5 months in a hospital bed at home, 3.5 years in ongoing physical therapy twice a week with my physical therapist, and every other week I see a psychiatrist for my concussion. My helmet is the only reason why I'm here, 100%. I would be dead without my helmet. The dent on the roof of the car was massive. With a helmet, I got a concussion, but and I didn't really appreciate that concussion for quite a while. But you should wear helmets. You can be riding your bike out here on the street, hit a little bit of gravel, 2 miles an hour. You can fall and hit your head just the right way. You can spend the next 6 months in a hospital bed in the ICU, intubated, not responsive to any stimulus, with your parents every day wondering if you're going to wake up. And the cost to your parents, the cost to society to pay for that cost, your parents in those 6 months will easily blow through any insurance they had. They'll now be bankrupt, and you will be a burden on society. Should you do that? Is that really right? It is your right, but I'm not sure it's right. So how about the educational costs? Teaching hospitals are more expensive. That was a little bit preachy this time. It's not quite so serious, but it is serious. I look at the parents in the audience, and it's, you should wear your helmet. Just do it. Don't do it for yourself. Do it for your parents. And, people don't wear their helmets because they don't like the helmet hair, right? Helmet hair. I don't like helmet hair. Helmet hair is so much better than windshield hair. It really is. So teaching hospitals, they're more expensive. because we've always said, we order more labs, we order more x-rays, because we're dealing with sicker patients. Well, actually, that's only part of it. We are dealing with sicker patients. The teaching hospitals, we get the sickest of the sick. But we're also teaching. So medical students, residents, they order tests that I wouldn't order after doing it for 20 years, right? Because I know I don't need that test. They're learning. So they're learning about tests that maybe they didn't need to get. When I was at UCLA, there was actually a study that compared UCLA to UCSF. They're similar hospitals, tertiary coordinated care medical centers, teaching institutions, taking care of the same sorts of patients, same sorts of populations. UCSF was half the cost of UCLA, half. Because at UCSF, they asked this question: why did you order that test? At UCLA, they said this at the top of their lungs as they're screaming at you. And you learn quite quickly, you may not know, why you'd order this test in somebody, but you're going to have every test for that attending, which is the professor, which is what I am. As they came around the corner and started screaming at you, why didn't you get that test? And so that's a major driver for cost, is sort of defensive medicine, which we actually practice out in practice, right? Because you're trying to protect yourself from lawsuits and the angry patients. We're also teaching nurses. We're teaching physical therapists. These all have costs. The nurses come to the bedside. They see something that's wrong, or they interpret as being wrong. They call the resident who says, oh, you're right, it's wrong. They order a bunch of tests, and nothing was really going on. Everything was fine. It was a huge overreaction. The patient was fine. So all those tests were not necessary and cost a lot of money. So hospitals are more, teaching hospitals are more expensive with increased waste. They're slower. And there are errors. So is there a benefit to it? I mean, I just finished blasting them. Is there a benefit to it? Well, I have to ask you, who will be your grandchildren's doctors, right? You don't step out of medical school and residency knowing how to take care of people. It's a training process. So you have to accept in the training process, there'll be some redundancies, some errors, some extra costs. And who will be your grandchildren's nurses? We need these people to take care of our future generations. And you can fill in the blank, grandchildren's whatever. That's where we teach people how to be care providers. Teaching hospitals, though, more than that. That's where innovation occurs. That's where the teachers learn from the students. That's where revolutions occur. Because the students don't know that they can't. You can't do that. We know that that's not possible. It's like, well, in fact, we just think we know. I give a talk actually that's, how do you know what you know? Because it's all made up. It's all, well, somebody taught me that. The more you know, the less you know. The more you know with somebody who said it with authority and you believed them, in fact, turns out to not be true. And that's the very exciting thing about being in healthcare, because that allows you to come at it from a brand new angle and go, wait a minute, I learned this at Davis or Berkeley or wherever you were as an undergraduate, and I know that if I apply those principles to this, what we've been doing all this time is wrong, because you have learned what I've never heard of before. Gels. They do gels in high school. The only gel I knew is my oldest brother used Brill cream when I was a little kid. That was the only gel I knew about. And now gel for making people's hair stand up. So it's David Starr said it. He was the president of Stanford in the 40s. He said the PhD candidates should be teaching the professors because the PhD candidates don't know that it can't be done, like the professors know that it can't be done. So the great thing about this is that the bright young minds like you are questioning what we know, challenging the evidence, creating new evidence, changing medicine. That's really the excitement about being in academic medicine. It's ever changing. There's a lot of emphasis on evidence-based medicine these days. You hear about it all the time. I think it's an insulting term. If a 60-year-old doctor's been out there doing it for 30 years, he or she hasn't been doing it because they're just getting up in the morning, well, I'm just going to do it this way today, see how it goes. They've been doing it based on their years of experience, their years of evidence. And the evidence-based medicine are these randomized prospective studies, right? Well, those studies are biased. They're funded by some drug company or some big industry, and they're structured to show that their product works. So they're often these non-inferiority studies, which, again, a scary term because we're talking about statistics. And non-inferiority studies are So the accepted standard of care is A. I'm going to introduce B, and I'm going to show, oh, it's not inferior to A. Well, then that gets marketed by the company as being better. It's 10 times more expensive, and it's better. Well, we did that study. It's like, well, actually, if you read the study, it just says it's not inferior to the accepted standard of care, which costs a tenth as much. So, companies are smart. They know that we don't really have time to study the studies carefully, and they also know that we may not realize that the study design was a non-inferiority study because, we weren't statistics majors. We're just, I was a human development major, not a statistics major. The NIH funding is going away. That was our best shot at unbiased research, but in that situation, actually, it was often biased by old people like me who knew that that couldn't be true. Some 25-year-old writing to grants saying, no, we know that's not true. The sun definitely rises in the west and sets in the east. Come on. So the NIH was a good source, but it was biased in the reviewers' approach to what we knew. So as in medicine, you need to review the literature with a skeptical eye and make sure your study samples apply to your population. And the challenge is that the evidence is rapidly changing on a day-to-day basis. There's a new movement out there talking about choosing wisely. You'll hear about it a lot, choosing wisely. Again, I think it's kind of insulting. Your doctor isn't trying to choose stupidly. He or she is choosing wisely, trying to choose the right antibiotic for you, trying to take together all the information and make the appropriate decision. But these are difficult decisions to make. And so they talk about partnering with the patients to make these decisions. Well, most physicians want to partner with the patients. Some don't. They want to just tell people and have the people listen to them. But some patients also don't really want to partner with you. And I was in England for 6 months. This guy says to me, Doc, you went to medical school. You just tell me what to do. It's like, okay, good, I can do that. And then other patients come in, like I said, with a stack of papers from the internet saying, this is the way I should be treated. It's like, yeah, that's not your problem. That's really a different problem. And so they sort of have an understanding and aren't really interested in partnering with you. And then you will have patients who say, I just want you to tell me what you think I should do. And that to me is actually the hardest conversation because that is, to me, is an incredibly arrogant thing for me to pretend like I know what to tell you to do. I can let you know all I know and provide you with the options, but ultimately you need to make that decision. I can't make that decision for you. If we talk about this, we talk about informed consent. Providing informed consent for surgery. It's a critical thing we have to do. We have to tell you about all the risk, complication, alternatives to our surgical intervention. The problem is you don't know what I'm talking about. There's no way you know what I'm talking about. I'm a surgeon. I went to medical school, started in 1980. When my surgeon was talking about the operation he was going to do to try to rebuild my shoulder, I had no idea what he was talking about. All I remember is he said it was going to hurt more than he goes, Mark, the thing is that this operation hurts more than any other operation I do. The pain's just incredible. It's like, oh, this is great. I'm so glad to know that. And that's all I really remember. But I signed my informed consent. He tried to tell me about it. But really, as a patient, do you understand what a colostomy is? Do you understand what an ileostomy is? Do you understand what it's like to be in this much pain? Do you understand? Did I understand that I would still be doing physical therapy 3.5 years after my crash? No, I didn't understand that. And I couldn't understand the pain associated with that or the frustration about a concussion. So there's no such thing as informed consent. There is a conversation that you can have on an active basis with your care provider, and that's important. So then this is the third rail. This is the third rail. Institute of Medicine, Dying in America. This is a report published 2 weeks ago by the Institute of Medicine. Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. This is the thing that we won't talk about in our country. Why do we need to die in hospitals? Why can't we talk about our wishes? Why can't we talk about the way we'd like to die? It's an important conversation. If you don't have that conversation, the guilt that your family has a year later after your death about whether or not you died the way you wanted to die, if you have that conversation, they don't have that guilt. If you don't have that conversation, they do have that guilt. You need to talk about the way you want to die. What are your beliefs? What are your wishes? If you have end-stage breast cancer that's metastasized to your liver, your brain, your lungs, do you really want to be in the ICU on a ventilator to die? No. Well, I don't. If you talk to doctors who talk to cancer patients, they don't make the same decisions for themselves that they make for their cancer patients. They know feudal care. They're like, give me a beer, I'm going to Tahiti. I'm out of here, right? But we have our patients die in the hospital at tremendous cost to the healthcare system. In the last year of life for people for end-stage disease, $38,000 spent in the last year of life versus $5,000. In the last month, $6,600 and $1,999 versus $325. Huge waste of healthcare resources. This could fund, vaccinations for children and everything. These are people with advanced disease, and this was published in the Medicare News Group on 6/13, June 2013. Huge problems. So prior to the crash, the financial crash of 2008, what was the #1 reason for personal bankruptcy? A personal diagnosis of cancer. You burned through your insurance and now you're bankrupt. Now you're on you're Medicare. So 2013, the #1 reason for personal bankruptcy, healthcare bills. So educational costs, tremendous cost to the student, deferred earnings, declining compensation, service underserved. If you're a 27-year-old woman who wants to have a family, you want to go into primary care, you can't pay off your medical school bills by the time you die. So that's a tremendous discouraging pressure on women going into healthcare to do primary care. So motivated students who are faced with overwhelming debt choose not to go into primary care, go into plastic surgery. I don't mean to disparage plastic surgery. So if you're going into, for the training in healthcare, service versus education, the federal government does subsidize the residency, so they expect some service for what they're paying for. And I'd remind you to say, oh, what industry are you entering? You're entering a service industry. So unseen drivers for healthcare, physician behavior. If you're a nice physician, you're not going to get sued. If you're aloof, you're going to get sued. That should accept healthcare. Uninsured versus underinsured, we talked about. Resource over and underutilization. Patient behavior, alcohol, smoking, wearing helmets. Patient expectations, patient satisfaction. A study done out of UC Davis. Increased patient satisfaction is associated with decreased outcomes because physicians are ordering tests that patients want that don't necessarily improve outcomes. Unseen drivers for healthcare costs, pharma, industry, insurance companies. Look at this, 2010, the CEO for Blue Shield of California, a not-for-profit, was paid $4.6 million for his salary. You're not making that as a primary care doctor. So that's a lot of people making money off of not providing you care. Insurance companies deny you payment, fight with you. When I had my concussion, I couldn't argue with the insurance companies, and they were yelling at me about paying for stuff and documentation, and I just couldn't think about it. My wife, fortunately, was there to take care of me, but if I didn't have my wife, I would have been saddled with huge bills. So I'm not a huge fan of the insurance companies. And people talk about not wanting government to control their health care and make health care decisions. Who do you think's making it now? For-profit and not-for-profit insurance companies that pay their CEOs $4.6 million. Huh. I would rather have the government making my healthcare decisions because they're not a for-profit institution. Pharma, they innovate, they take big risks. I agree with that. They get bigger rewards. I think they're kind of like oil companies. I don't really feel too sorry for them. The front page of the Chronicle this morning, $1,100 a pill for an anti-hepatitis C drug, $94,000 for a 12-week treatment. Great, it'll cure hep C. $94,000. So I'd say they're doing okay. Their return on their R&D is pretty good. Industry innovates, takes big risk, big returns. I think they're like oil companies as well. They're not in it. Their shareholders are doing well. So in summary, this is a complicated conversation. Now that I'm being filmed, I probably have alienated a lot of insurers and pharma and all that. But anyway, there are multiple viewpoints, and certainly there's argument back. I mean, the farmer comes back, well, we take the big risk. I go, well, you're doing pretty well. That big risk is paying off. There are multiple viewpoints. I think we should have an honest discussion. Should we allow deaths to occur due to inability to afford or access health care? My answer is no. I don't think that the richest country in the world shouldn't be doing that. Should we allow costs to increase over personal decisions without shared responsibility? I'd also say no. I think we should be involved and say, okay, Mark, you want that test? It's going to be expensive. It's going to cost the healthcare system, so you need to help pay. As a chief of staff of a major teaching hospital, I expect high quality care. I expect the best quality care, not just high quality, the best. We should be the best. I think it should be cost effective. I think it should be safe. I think we should have dedicated faculty and staff. We should provide excellent service. There's no doubt about it. But we should not forget those other points. And we should always be a learning institution. We need to learn on a day-to-day basis how to do better, whether it's better technical care, whether it's better service, whether it's better explanations of what we're doing. We need to do better every day. Thank you.